So we have our last presenter of the day. Uh,
Respected
Sweat
judges,
gland. Yeah, yeah. Please, madam. Please go ahead.
respected judges, uh, I'm presenting on behalf of Dr. Shebin. My paper is on sweat gland tumors of eyelid, a clinicopathological study. As we know, sweat gland neoplasms are rare adnexal tumors with lots of diagnostic challenges, and there is lack of consensus regarding the nomenclature and classification with multiplicity of terminologies, both eccrine and apocrine gland. To present the clinical histopathological features and management outcome of patients with sweat gland tumors of eyelid. It's a retrospective observational study. We had 15 patients during a period of 10 years done in a tertiary ophthalmic center. The mean age at presentation was 55.6 plus minus 17.4 years. Duration ranged from 1 month to 20 years. So coming to each tumor, one is hydrocystoma. We had 5 patients. The mean age was 52 years. Here we can see the pathology is apical snouts and papillary projections into the cyst wall, suggestive of apocrine origin. All patients underwent cyst excision with biopsy. Intraoperatively, there is rupture of cyst wall in 2 patients, and 2 patients had a recurrence. Next is condor syringoma. We had 2 cases. One was 66-year-old with a history of 6 years and history of INC in the past. Second was a 19-year-old with a recurrent attack since 2 years of age and status post removal 4 times back. Both the patients underwent wedge excision with the biopsy and proved it as condor syringoma. Histopathology showed a mixed pattern in this case. Coming to cystic papillary apocrine adenoma, we had one patient, 62-year-old, with a history of 8 months. Here, the cyst lined by, as the name suggests, adenomatous proliferation and papillary formation. Coming to eccrine poroma, we had one case, 60-year-old lady, history of 20 years history, had undergone shave excision from elsewhere and present like a non-healing ulcer. She had endophytic growth into the dermis with a focal irregular acanthosis. Coming to eccrine porocarcinoma, that's the malignant version. We had one patient, he was 66-year-old with a subrose swelling since 8 months. It was mimicking basal cell carcinoma. It had, the pathology was a circumscribed neoplasm, the cuboidal cells in the vesicular nuclei and ductal lumen. Next is apocrine variant, apocrine adenocarcinoma. This was a case of apocrine adenocarcinoma. It was also mimicking like a basal cell carcinoma with the roll-out edges, and 62-year-old male with the 4 months duration. Systemic evaluation was normal as it can have associated secondary. Next is mucin-producing sweat gland carcinoma. We had 2 patients. One was 60-year-old and of 6 months duration. Second is 60 with the 1 year duration. This was the typical clinical picture. There was loss of lashes. Both these patients, since the lesion was small, underwent wedge excision with the clear margins and biopsy and reconstruction. Next is mucinous adenocarcinoma. We had 2 cases, 73 and 83-year-old with a history of 1 year and 2 years duration. Systemic evaluation was normal. So coming to the clinical presentation, we had 13 patients with the lid margin lesions, 1 with a subrow, and 1 had anterior lamella sparing lid margin. 5 underwent cyst excision with the biopsy, 8 underwent wedge excision, and 2 underwent wide excision with the lid reconstruction. Margin clearance was there in 10 patients except in 1 case of hydrocystoma. Histopathologically, 9 had benign lesions and 6 had malignant lesions. Follow-up, no recurrences were noted in any of the cases over a mean follow-up period of 23 plus minus 5.5 months, except in 2 cases of hydrocystomas. So coming to the discussion, hydrocystoma, it can be either eccrine or apocrine. Clinically, it is a translucent, solitary or multiple. It can have syndromic associations. In our study, none of them had any syndromic association. Condor syringoma is like a pleomorphic adenoma with a mixed pathology. Similarly, eccrine poroma, only 11 cases reported till date. Here, the possibility for malignant transformation to porocarcinoma or recurrence is there. Porocarcinoma arises de novo as a primary tumor or can develop from a pre-existing benign poroma after a long latent period. Regarding the apocrine adenocarcinoma of the eyelid, multiple terminologies. All the endocrine mucin producing sweat gland carcinoma, apocrine adenocarcinoma, mucinous adenocarcinoma, all belong to this category. Especially this endocrine mucin producing sweat gland carcinoma is in situ precursor of invasive primary mucinous sweat gland adenocarcinoma. it is important to rule out primaries elsewhere. So coming to the treatment aspect, should we excise the anterior lamella alone? Actually, no. There was a case report reported. This was a recurrent lesion which had been removed by lamellar excision. So lamellar excision, if you do, you can have recurrence later. In benign sweat gland tumors, should be excised completely. Again, yes, malignant transformation of the benign cutaneous mixed tumors are reported. So to conclude, eyelid sweat gland tumors are very rare. Clinical presentation varies except hydrocystoma. The identification is it will not cross the posterior lash line. Cystic areas can give a clue to the sweat gland origin. Long duration and lack of conventional malignant features does not rule out malignant lesion. Consider marginal clearance and complete excision even in benign lesions of sweat gland origin. Thank you.